Okay, thank you, Craig. I watched that video last night with my family, and my youngest son, who's 9, said, "Oh, Dad, you've got an awesome job." I said, well, "Oh, great, great you think that. Why is that?" "You get to play dominoes at work." So, no, I think it's a very, very good and a very, very poignant video. So, we had, just over 3 years ago, Healthcare Improvement Scotland and Jason and the Scottish Government said, let's reduce mortality in Scotland, but let's reduce it even faster. And he said, how can we do this? And myself and Dilip Nathwani stupidly put up our hands and says, let's fix sepsis. And Jason's response was, what's sepsis? And I bared in mind that he was a dentist, so he probably wouldn't know, but that was the same response as you get from a lot of different people. Yeah. Well, but you're going to slag me off anyway, so I thought offence is the best form of defence. So, and at the first learning session, we made the analogy of the fight against sepsis and actually the collaborative to actually climbing Mount Everest. And I actually believe that it's a very, very good analogy. Base camp was our STAG audit report, which we'll talk about next. And for every camp 1, 2, 3, and 4, I believe that's been our learning sessions. That's our time to regroup, find out what's important, and take us to the next level. And as you're all aware, we've got learning session 4 coming up in November. And just after that, 5, is it? Oh, there you go. Well, there you go. I don't even know my maths. Learning session 5, what I believe that is a Hillary step. So that's kind of the last 40-foot vertical climb before you hit the peak of Everest. So what have we done? Well, again, there was the STAG sepsis management audit, which showed back in 2009 that our care for sepsis had room for improvement across Scotland. It was done over a 3-month period, and they looked for signs of sepsis within the first 48 hours of admission to hospital. And over those 3 months, across every hospital, we said that was about 5,000 emergency attendances and admissions with sepsis. At that time, in 2009, only 71% of our patients had an early warning scoring system. 34% of them had severe sepsis, so the predicted mortality of about 30%. We only did 21% of blood cultures in time. 32% of patients got antibiotics in time, and only 70% of patients got IV fluids on time. And this isn't me doing the all or none, which should have been far, far lower. So again, at our baseline, so at our base camp, the defect rate for sepsis management in Scotland was anywhere between 18 and 74%. And I also believe that we've come from the idea that people didn't talk about sepsis. They didn't write sepsis in the case notes, and no one really knew what it was. I think that was due to a fear, much like Lord Voldemort in the Harry Potter movies. It was 2 years ago, we signed up, Scotland became the first nation in the world to sign up to the World Sepsis Declaration. And I just like showing that picture because it always makes Alison angry. And also, we've come on great leaps and bounds, and working closely with NES and colleagues within NHS GG&C, we created a national early warning scoring system and a sepsis app. And that was an award nominee and one of the 3 finalists in the Scottish eHealth Awards. And I actually think things like the sepsis screening tool in the News app is actually one of the key learning for us as a result of the collaborative. Because as you're aware, we've had an evaluation of the collaborative. We want to know what works well, why it works well, for whom it works well, and under what circumstances. And actually, one of the things that we've picked up is the need for some ongoing education of people. So we can bring everyone together in a room for a national learning session, but it's about how do we disseminate that knowledge and how do we get that out there. Our learnings from the evaluation, we've got evidence of good uptake of the sepsis work, but more importantly, we've got evidence of sustainability. There's always a danger if you're starting off something and it falls away later on. I can't reiterate the importance of early warning scoring systems, and personally the National Early Warning Scoring System. There's a publication in Resuscitation which shows that NEWS, the National Early Warning Scoring System, is better at predicting a deteriorating patient, better predicting sepsis, death, and multi-organ failure than 33 other early warning scoring systems out there. Okay. NEWS is validated in the emergency department. It is better than the Manchester triage system at detecting a deteriorating patient in the ED. It's been validated in the pre-hospital setting as well with the Scottish Ambulance Service. So it is very, very good. And there's a tendency out there that we're all human beings. We all like to cut corners. And then one of the ways we can cut corners is we can just say, well, let's just skip the news and do SIRS screening. But if you skip the news, you're becoming too sensitive and you're going to take up too many people. Because if you just look for SIRS, you'll pick up too many patients. If Jason runs for a bus on his way home tonight, he'll have SIRS because he'll be tachypneic and tachycardic. He obviously doesn't have sepsis, and we shouldn't be giving him antibiotics. So I'd like to reiterate the importance of the National Early Warning Scoring System. Again, one of the key findings from the evaluation is the importance of using the hour. We encouraged it from Healthcare Improvement Scotland as well. We saw healthy competition across all the boards, and actually we saw people getting the delivery of the Sepsis 6 down to about 20 minutes. In fact, I was unfortunate enough to be admitted to an emergency department, not because the emergency department was bad, but because I was in an accident a couple of months ago, and I'm lying in a bed feeling awful, and I heard a nurse say next door, "Quick, hurry up, the sepsis man's next door." So I don't know if that was a good thing or a bad thing, but I suppose it means that we have uptake and we have sustainability, but I don't think I can get knocked down every week, because otherwise that's not a good idea. But what we've figured out about that is the importance of using the hour. You have an hour. You know, someone who gets antibiotics at 15 minutes, at 10 minutes, at 5 minutes, doesn't do any better than someone who gets antibiotics at 59 minutes. It's for every hour's delay in antibiotics, your mortality increases by 7.6%, not for every minute. Okay, so actually, if you do things too fast, you may have some unanticipated consequences. So you could be penicillin allergic and we actually give you a penicillin. We may not follow the best antibiotic for intra-abdominal sepsis or for a community-acquired chest infection. We may calculate the wrong dose of a drug or the wrong route for the drug. So it gives you time to sit back, have your thoughts, and make sure you're given the right antibiotic, the right indication, the right dose. Sepsis, we like to talk about the Sepsis 6. I mean, I like to think it's a very simple thing. Come on, how difficult is it? We're only asking you to do 6 simple things once you've identified the sick patient. But actually, when you take each individual element and break it down, it's a very, very complicated procedure. And that's that's not taking into account the actual screening for sepsis and the recognition of the deteriorating patient. So actually, if you use process mapping to follow your patient through from the ED to the acute medical unit and to other wards, you'll actually see all the complex interventions that are needed, and then you'll see where there's room for improvement. Clinical leadership is key. It's key because if the consultant or the charge nurse is interested, the rest of the staff is very, very interested. Again, we see a lot of people talking about, but with every board I visit, and we're going to Inverness tomorrow, we'll see lovely boards up as you walk to the front door saying, this is our compliance with X, Y, and Z. We're actually realising these boards are useful and they're helpful, but actually don't mean a lot to the staff, and they may not mean much to the visitors as well. And we're now seeing far greater use from these boards. It's actually when people talk about it in the ward rounds. They talk about it in the safety briefs, and they actually say what the boards mean. So actually, you may not need to go to the board, but actually you could say, well, last week our compliance was 85%. Week before that, it was 95%. What was the difference? And allocate people with the roles and responsibilities. So it's importance of using data, but using your data in the correct fashion. And that ties in nicely with your clinical leadership from the medical staff and for a need for some type of ongoing education. So the medical staff educate people in ward rounds, and also I believe the nursing staff should use that. And again, we as boards need to disseminate that knowledge, and I believe things like the Sepsis app and other things we've got some ideas on are good ways to do that. And that ties us into this opportunity for electronic systems, be it a mobile technology, be it mobile apps, or actually using what's already out there. A lot of boards have track here. You can have sepsis screening protocols and sepsis tick boxes that will give you all the blood to do for the septic patient. So take advantage and use technology to best effect. So a couple of quick slides of how we're getting on. Well, as you can see, this data goes right up to May of this year. And our early warning scoring across the whole of Scotland, the boards that are reporting, is about 95 to 96% accurate. And that's a great idea and good reliability within healthcare. Antibiotics within the hour, well, when we started in January 2012, we had 2 boards reporting. We're now up to about 10 boards reporting, and we're managing to get antibiotics within the hour 80% of the time. And again, it's the identification of the sick patient, escalation, and appropriate treatment with fluids and antibiotics that makes a huge difference. Percentage with sepsis 6, so that's an all or none measure. You've got to do all 6 things within the hour or you fail. As you can see, that's increased and it's come down a wee bit over the last couple of months. And I do believe that's because we're at the Hillary step. We've got that final hard push to get there. And actually things like tonight, going back doing things on your own board and the learning session 5 in November is our opportunity to do that. So while it's a wee bit disappointing, a slight dip, I do believe if you look at things like the antibiotics within the hour, these things, the things that matter are getting done. It's things like monitoring urine output balance. These are the things that are pulling us down, and the things that's difficult to get people to understand a sense of urgency and the importance. And how has this affected mortality in Scotland? Well, we're doing a lot of work with mortality in Scotland with sepsis, and we hope to be able to share you the results of that in the learning session in November. But as you can see, raw mortality for sepsis in Scotland has come down over the last 5 years. And I'm confident that's due in part to the hard work of everyone in this room and across Scotland. So we're almost there. I believe we've got the final hard push to just get there. This is a key integral part of the deteriorating patient work that's been led by Healthcare Improvement Scotland. And I really like this quote by Edmund Hillary. Alison's my Sherpa Tenzing, and he said that I'm a lucky man, I've had a dream and it's come true, and that's not a thing that happens often to men. And I think you all share the same dream. So I just want to finish up before I pass over to Yvonne Cowan from Ayrshire, not Ayrshire, as it said in the slide. The Sepsis Collaborative is part of the Scottish Patient Safety Programme, and it's actually across 3 of the main pillars and the main programmes of acute adult, maternity and child health. I always say maternal and I get it out for that. Primary care and mental health. So we're going to hear some work in acute adult tonight, and we'll hear some work that's been done in maternity and child care. And there is work out there being done in primary care with regards to sepsis, and there is work being done out there with the ambulance service as well. So there's a lot of work being done, and we don't have the opportunity to showcase everyone tonight. But with that, I'd like to thank you for all turning up. Thank you for your time, and I'm going to pass over to Yvonne Cowan from Ayrshire.